What's up, y'all? Welcome to the Sports Medicine Broadcast. We're talking about building relationships with your local emergency room. I've got Dr. Gail Marjoram. Dr. Gail is currently practicing as an emergency room doctor. She's been practicing for 32 years, so she has lots of experience. So this episode is focused on what we can do as athletic trainers to build that connection, to better communicate, to better treat our athletes and our patients and get a better result. And so there's a lot of times where we can sit back as athletic trainers and say, well, they're not doing this, they're not doing this, they're not doing this. But one of the things that I keep going back to is whenever I talk to our school board member, he said, the reason we don't know who the athletic trainers are and what they do is because you haven't told us. So in our leadership series at the beginning, like in October that John led, we talked so much about, well, what are you doing? What are you doing? You gotta own that. You gotta take responsibility. And so this isn't about, hey, Dr. Gail, you're not doing enough. This is about, hey, Jeremy, you are not doing enough. What are you doing? How can you improve, Jeremy, with the relationships and increase those patient outcomes? And so, again, that's the focus. Some of these are going to come across as gripes from athletic trainers. But let's focus on what I can do as an athletic trainer and how we can improve that relationship and improve the patient outcome. This episode is sportsmedicinebroadcast.com/ER doctor. Again, sportsmedicinebroadcast.com/ER doctor. And again, Dr. Gail, thanks so much for working all night and then joining me on the podcast this morning.
No worries. Looking forward to it.
All right, so let's just start off with, I mentioned, you're in Jacksonville, Florida, 32 years, St. Vincent Hospital on the South Side. So tell me just a little bit about your story of getting to where you are today.
So I started training as a family doctor because I just wanted to be able to do everything. But then I also got certified. So I'm boarded in emergency medicine, and I've been doing that for the whole time. Lived up and down the East Coast doing emergency medicine. Been doing a lot in the community pretty much for the last 22 years because I was a volunteer Boy Scout leader for years and ran all their first aid and out in the wilderness first aid, which is a lot of fun, which is how I got to your sportscast, and then Girl Scouts for the last 12 years. And that got me to here. And then my son's doing a master's in athletic training. So it's like, oh, cool.
Okay, so he's going through the MAT program. Where is he going through?
He's at not the MAT, but it's a special exercise physiology at the University of North Florida.
Very cool. And so this isn't exactly what we're talking about. What's he planning on doing with that?
He doesn't know. He's really into working out. My husband and I have worked out our entire years. It's the only way to stay healthy. And so he started exercise physiology. He doesn't know if he's going to go pre-med, pre-PA, physical therapy, sports training. So he's kind of keeping his options open. Probably affected by his girlfriend too. So.
Okay, so you said your son is kind of involved in athletic training in some form or fashion. Then what other experience other than this podcast today do you have with athletic trainers?
Not a lot. Just what you guys send me to the ER.
All right, have you ever had an athletic trainer come and meet with you or say, hey, I would like to meet with you?
No. And It'd be really hard in Jacksonville because we are, oh my Lord, I think we have 5 hospitals in our community. It'd be really easier where I've lived before, where I was the only hospital in the community and I never knew any of them. And I thought, this is great, All
right, so even though you are working, again, here in Houston, we have a major medical center. I'm in Pasadena, so it's really like Southeast Houston. And there's the major medical center, but there's also stuff all around us. I mean, I literally could probably count like 100 hospitals or ERs or clinics or whatever that I could possibly send somebody for an X-ray or something like that. And so how realistic is it for someone to call up where you work and say, can I come meet with the doctor?
Not everybody will be agreeable to it. To be honest, I think the most productive thing that you guys could do would be to have like a 3x5 card that when somebody comes in, it's got your name, it's got your phone number or your email, for contact. This is what I saw at the scene, because a lot of times, especially for concussions, the kids don't remember, the parents don't have a clue what's going on. And I don't have anybody hands-on that was at the scene to tell me what was going on. Did they have a concussion? What was, to how to go from there. And that way, actually, I call people back or send them an email. It's like, this is what we found, da, 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 da. So that would be really useful.
Okay, so we'll get into that just a little bit about like how you want to communicate, but I was just thinking logistically, um, what does that look like there? I'm not familiar with Florida or the South Vincent, South Side area. So, are you in a similar situation to Houston? Is there several large hospitals and lots of like ready clinics or
Yeah,
neighborhood ERs or whatever like that?
so, if you wanted to actually go to the ER, you would call, ask for the medical director, and say, you have a lot of injuries. You're a local. You're working with a sports team. You'd like to send your patients to our hospital, and she'd like to just come meet. Just so you have a hand-to-hand contact, and you guys develop a relationship. And that would be really, I think, just about anybody would be agreeable to that.
All right, so we're just calling the local ER director and saying, "This is who I am. This is my situation. We have kids coming there. I want to improve the patient care. Can we meet and discuss that?"
Yeah.
Okay. All right. So tell me a little bit more about your time in the Boy Scouts, or some of the stuff that you saw there with the Boy Scouts.
Oh Lord. You have your your normal dislocated fingers, sprains, lacerations, uh ankles. We had one of our kids that actually had a scrotal torsion that had to go to the emergency room. I did not take care of that at camp. It's like, nope. um We actually didn't have any head concussions. It was more prevention, actually. We'd be out, at a camp, and all of a sudden there'd be a thunder lightning storm, and everybody's standing in the open field. It's like, guys, we got to get away from this. Making sure they had enough water. I see a lot of injuries or people coming in middle school, especially for heat illness in the summer, because the coaches are coaching and they're not thinking that they need to tell the kids, you need to eat this, you need to drink this, so you don't make your brain swell and die. So those have been the most interesting.
Gotcha. I just figured, with Boy Scouts, kids with knives, and you're in fire, there would be some of those type of injuries too that we might not see here.
Not too many. No, the kids are pretty good. A couple puncture wounds. The worst laceration was my own kid. That they call me. He's like, we'll wait till you get here.
There you go. So do you carry like a full like suture kit there with you to camp?
Oh yeah, I have actually it's a Boy Scout backpack that's, oh Lord, it goes all the way around my waist, and I literally have it full. And that's one of the reasons I was listening to one of your podcasts is what kind of things do you guys have? So I have a drug section, wound section, sprain section, everything's, all broken up, and then your ticks. The worst was one kid that had 26 ticks in his scrotal area. I was like, oh, that's way too many.
Yeah.
He was laying in the woods.
Was he laying in the woods naked? I mean,
No, he was been laying there for a while, and there were little deer ticks, so
crawl right on up there.
yeah.
All right, you mentioned if I was to send a kid to you, so like their parents take them, that we have some sort of note, like a 3x5 card, or maybe we print off the injury report. But on that, you also mentioned having like my name, email, phone number, that kind of thing. Basically, some contact information. Um, did you have you seen any athletic trainers do something like that, and what kind of variations have you seen with that?
I haven't seen any, and I would just love to get that, especially when I was looking at some of the comments, that people had made that we'll respond to, for me to get back to you guys. Parents, really, as I said, they're not there at the time. Usually, they're over on the scenes. They're not there during the injury, so they really don't have a clue. And of course, everybody's worried about their kid having a concussion. So even if you had a report that you filled out and the parents just screenshotted it, you wouldn't even have to send the paper. They could just screenshot it with their phone and say, okay, this is what was going on at the scene. And that way it would make sure nothing was getting lost. But that would just be so helpful.
All right. So what about when they come in via ambulance?
We haven't had too many. Same thing. It's EMS, and EMS doesn't always get it right. So, yeah, hearing from you guys right there at the scene is what I'd like best.
Okay. And again, obviously you're a doctor. you know the anatomical terms, directions, that kind of stuff. So is it best for us to just keep it simple? All right, dislocated ankle, I reset it, he had good pulse, or would it be better to, does it make a difference to you if it's simple or complex, just as long as it's there?
As long as it's there, and the simpler the better. I can't even remember traction, distraction, displacement that the orthopedist used. It's like, it was bent outwards and we put it back. I mean, it's fine.
Okay, so simple is better to make sure that we're on the same page, but if you can use the valgus or medial lateral, those type terms to help clarify, but the athlete is also going to be there and say, well, this is what happened anyways.
A lot of times they don't know. A lot of times when they fall, it's like, how did you fall? Well, I don't know. If you guys knew that, okay, it was an inversion, it was an exversion, they were hit from the side, especially for like knee injuries, because then if they're hit a certain way, then I have to worry about a vascular injury, and it changes their workup and it changes the injuries they can have.
All right, so up to this point, we've kind of covered what we can do as far as getting them to you. And so, in summary, if we send something, so if we print off a piece of paper that has our name, email, position, and then just a place to write the notes and send that with the kid and say, hey, give this to the emergency room doctor. Or, again, I'm not sure if EMS would actually transfer that, but I guess, again, it goes back to building relationships with them and setting up that expectation. But basically, sending something as far as a note and a way to contact us is going to be the simplest, most effective way, in your opinion.
Oh, absolutely. And I would say, show it to the nurse, but hang on to it till the doctor sees you, because sometimes the nurses lose stuff. It's bureaucracy, and especially
Okay.
in ER, things just get lost.
All right. So again, that's good. That's education on our part. When you say, okay, hey Johnny, give this to the doctor. You can show it to the nurse, but hang on to it. And that way the doctor can contact me and I can be in direct contact with the doctor. And then if you, Dr. Gale, want to put that in the file or hand it to your nurse for them to follow up with, then that's up to you. But at least now we've kind of made that connection.
Yeah, and if I had any questions, I could actually call right away. So
Very good. And one of the things you mentioned was heat illness is one of the things that you see a lot. And I don't know the situation, athletic trainer situation there in Florida. I know here in Texas, most schools have an athletic, especially the 6A, which is our largest division of high schools, have an athletic trainer. But almost, I would say maybe 10% of the intermediate or middle schools have an athletic trainer. And so you wanted some feedback from us as far as how can you reach out to the athletic trainers. Do you have any idea what the athletic trainer situation is there in Florida?
no, and if you guys had any tips for me to reach out, so that way I could, because of course their feeder schools are going to be the middle school, and that's where I'm seeing the injuries from. So if we could just get some information out to the middle schools, and then it improves their relationship because they're feeders for them.
Okay, so I after you asked that question, I went back to Facebook and said, "Hey guys, how can Dr. Gale reach out?" And then, so in general, a ER doctor can reach out in these ways to athletic trainers, which again, I feel as an athletic trainer, it's my responsibility. So I should be reaching out first, uh, not waiting and expecting you to reach out to me. However, since you asked, this is what Julie Dever says: is the school email is one of the best ways for her, and that's easily accessible if you really wanted it. For the most part, schools have that on their website. So you say, okay, well, I'm seeing a lot of kids from Jackson Intermediate. Let me look on there and see who their athletic trainer is. Or they go up to Pasadena High School. Let me see. Okay, Jeremy Jackson is listed as an athletic trainer or sports medicine director or whatever it is. Let me email him and say, hey, these are the issues that we continue to see. Is there a way we can meet and communicate or educate coaches and that kind of thing?
Cool.
And then Justin, actually, he may be in Florida. Justin Strife. He said start with reaching out to the supervisors of many ATs. So he actually works in a hospital system that reaches out. So here at Pasadena, I am employed by the school district. I work specifically at Pasadena High School. So I'm not employed by a hospital. I don't do part-time somewhere else. I'm here all day. This is my only job. And so for him, he was like, reach out to the hospital system. So our district just partnered with Houston Methodist. So it may be in a situation, obviously that's a hospital there in and of itself. But if you're the one that's right here in the neighborhood, say neighbors ER, you just reach out to Jace, which is the director there at Houston Methodist, and say, hey, Jace, this is what we're seeing. Is there a way that we can communicate with you and your athletic trainers about how we can educate coaches, that kind of thing? So I guess first would be finding out the athletic trainer situation in your area, and then going from there. So after this, I remind me, and I'll specifically send the email to some of the people I know in Florida, and hopefully we can get that, get you pointed in the right direction, get you connected with some of the people that may be able to help you.
Perfect.
And then Justin continues. He was saying they have, their situation is unique, and I have that way down in the bottom of the notes, but they have a consultant or a doctor who does part-time in the ER and part-time with the sports medicine program. And so that helps coordinate the events. And so I don't know if you guys have a sports medicine program there as part of your hospital system, but just going over and meeting them, and then meeting their director, their athletic trainers, or inviting their athletic trainers in, saying, hey, why don't you come in for a couple hours this day, or whatever it is, and that way you can see us and we can go from there. Mike McKinney, he is in Boston, and he says that they have identified a medical liaison for their facility, that the athletic trainer can contact to access information following emergent referrals. So for us here, I have a emergency room hotline for Houston Methodist. I say, hey, I got this kid coming, or they should be coming, because that doesn't always happen either, right? So I say, hey, mom, take them to Houston Methodist, and then they go the opposite direction. Okay, that's fine. That's your choice. But so I say they should be coming, and then I email our athletic trainer, who is the between Pasadena and the hospital, and then they'll also kind of forward that information, and it helps because they're employed by the hospital, and so that goes in between. Again, my situation is not exactly your situation, and so we just kind of take it from there. But identifying that liaison, or kind of like we talked about, the office manager, having them just reach out maybe the way there, or just going to the school and saying, hey, coach, this is who we are, this is what we see, we would like to meet with y'all at some point. Can we set it up? And then Carrie Beth Williams also mentioned something similar. Call, text, or email, or send info to the school attention athletic trainer. So again, if you're looking at middle schools, intermediate schools, they're most likely not going to have an athletic trainer. But if you send it to the high school and say, this is who we are, this is what we want to do, can you connect us, or can we collaborate on this? Because most athletic trainers would be willing to do that, especially if they have the backing from a local hospital, medical facility, saying, hey, this is what we want to do. We want to help prevent injuries. So those are hopefully some tips that help you connect with us.
Good.
All right. So now there was a lot of comments about, like I said, there was a lot of complaints or gripes. And again, we're focusing on what me as an athletic trainer can do to help bridge that gap with you. Okay. So I want to start off with this is John Harmon and a couple other people, Jason Kruth and Jason Broad, both said the emergency department's job is to save life and limb. They're there so that the patient doesn't die. Anything else, then that's a bonus, right? So they're making sure that the patient doesn't die. They shouldn't be there for treating a routine ankle sprain. They shouldn't be there for treating a cold, right? They're there to make sure the patient doesn't die, or doesn't lose a limb. And so anything else, they should be referring. And most of the time when I see a note, it says follow up with PCP, follow up with ortho, that kind of thing. So again, framing all of these complaints within that mindset of the emergency department is there to prevent death or loss of limb. Does that work for you? You kind of agree with that?
Well, emergency residencies are trained to save lives. And so they actually don't focus on the minor injuries, and they're really not interested in the minor injuries. And that's where my training in family practice gives me a different, because it's like, okay, we're taking care of the whole product. Yeah, you got people that are dying, and then you got these kids that need somebody right now. They can't get into their doctor the day of an injury because there's no appointments open. So we're it. So we need to open our minds a little bit more to the service. and work with everybody. But that's why people will get that attitude from some of the docs, is like, well, this is below me, but that's our job. So they have to kind of embrace it. And they're also not experienced when it's like really mild stuff. The traumatic mydriasis on the girl whose pupil was blown, and you guys were worried about a head injury like about 6 months ago. That you guys wouldn't have that expertise, and not everybody does. So it's experience. People have to keep up with training constantly. I mean, I've been doing this for 32 years, so I have to literally every month I'm learning new stuff.
All right, so that is one of the comments. A couple of people have commented. You're talking about head injuries and being up with the latest training. Let me see. Basically, we get notes saying closed head injury, no concussion. But in the state of Texas, and most states have something similar, that if the athletic trainer, the coach, the athlete, or the parent suspect a concussion, then they have to be treated with a return to play protocol. And then also, just because there wasn't a fracture or loss of consciousness doesn't mean there wasn't a concussion. And again, understanding that the emergency department is there for saving lives, unless they're specifically trained like you. What can we as athletic trainers do to help grow the understanding in an emergency department, so that they're not telling the kids, hey, you don't have a concussion, but instead they're saying you don't have a fracture, or you don't have a brain bleed from the CT scan, but you need to follow up with your PCP or athletic trainer for the concussion stuff?
So that's where you're actually going to have to help educate the docs that don't already know what's current. One, the definition of concussion varies depending on if you go to the American Society of Neurology Association or the Sports Association. From the emergency medicine, a concussion for us is, and that's why we need your at the scene evaluation. They had to have a loss of consciousness, or they had to have confusion or disorientation or amnesia at the scene, or a focal neurological sign. If we don't get that history, and the kid may not remember it, then for us, they have a head injury, it's not a concussion. And so we don't do the return to play. So if you want that regardless, we need that sideline input. And then also on that card, you could say, if they don't have a severe concussion, then just let us know. We can institute the return to play protocol, because they may not even know it. I've actually incorporated it to my discharge documents. So if they don't already know it, then they have it. So that would be helpful to instruct the docs and cover that lack.
All right. So again, it goes back to the communication there. So say I'm an athletic trainer in your area. I haven't ever met with you, and I send you a note saying, "Hey, doc, they got hit in the head hard. They're having trouble remembering," that kind of thing. We would just want to get them checked real quick, make sure there's no fracture or anything like that. But we're going to put them through the return to play protocol. Can you note that on your card? Is that about what you would like, or does it need to be worded differently for you?
No, that would actually be fantastic, because most people, as I said, most of my partners, of course, I'm interested from the family practice, so I do the return to play stuff. And if they don't bring a form, then I have one already printed off, and instructions for the parents, because the parents are just completely clueless. So it tells them, no computers, no TVs, at least for the first night, which pisses the kids off. But that's okay. So yeah, that would be fantastic.
All right. So again, following along that line, I know that Israel, Gary, Samantha, Carrie Beth, and there was a couple more that they kind of mentioned about being using the CT scan to rule out a concussion, and just understanding the definitions and the laws. So someone maybe in your practice that is not up to date, how could I, as an athletic trainer, approach that to where, because you are a more highly trained medical professional than I am. And so how can I approach that saying, these are the latest laws or expectations with concussions. I just want to make sure we're on the same page.
Actually, you could put, that would be one thing where the form would be used. So right now in the emergency room, the standard currently is, are you following the Ottawa head rules? Or they're called the PCARN, the pediatric emergency head trauma rules. and you could put that on there, please tell, when you send the information back to me, tell me which head rules you used. And the head rules are going to tell us, do we need to do a CAT scan or not? Because parents come in and they think that immediately their kid's going to get a CAT scan, and they don't realize that we've gotten really cautious with the radiation, because you get enough CAT scans, and down the road you're going to end up with cancer or thyroid cancer. So we're being really cautious. So we now have a rule protocol that we follow, that you guys, I sent you the apps, so share those. That you guys at the scene can say they probably are not going to need a CAT scan. They may or may not, but they need evaluation. And that way we're being cautious, because what we're looking for with the CAT scans is, do they have a surgical bleed that I'm going to have to put a hole in their head? If they just got a little ding, it's not going to change your treatment, then I don't need to expose them to radiation. So that would also make sure the docs, which head rule did you use, so I can document it for my kids.
All right, so
a backwards way to get them to share what protocol they used.
There you go. Yeah, that's excellent. That's what we're looking for. Is I don't want to come across as I know more than you. I want to, hey, let's figure out how we can be on the same page and we can improve our communication. And just saying, hey, can you explain to me which head rule to use? And again, Dr. Gill provided a lot of different resources and links, and I have those again, sportsmedicinebroadcast.com/ER doctor. I have ER doctor squished together. There's no space or underscore or anything. And so she gave me all those links, and I've got them in there as we discuss them and go over them. That you don't have to remember them all. Again, sportsmedicinebroadcast.com/ER doctor. One of the things, again, this is being streamed live on Facebook, and I got quite a few comments from Adam Halpern, which from Innovate AT. He says one of the things that ATs need to embrace are real value and strengths. Our unique value proposition is ATs are highly qualified healthcare case managers and our musculoskeletal experts that refer to the next level specialist. So this is the value that we bring healthcare systems in a way that no other discipline can deliver. So one of the cool things about having you on here is that I get to share what athletic trainers do. And so there I am, reading Adam's quote, just about athletic trainers. You said you have some experience with your son being in the field or in the profession, but now you're getting a little bit more understanding of what I do, and you'll be able to share that with your colleagues. And so that'll have like a ripple effect as well. So Adam, thanks for coming in there and reminding us that this is not just about us, but also not just about me or Dr. Gale, but about improving the perception of athletic trainers as well. So.
And to be honest, you guys are more up to date on the musculoskeletal stuff than we are, because we're not doing that daily. We're like, putting holes in people's lungs because they're collapsed, and, saving them from a heart attack, or putting pieces back in place that got cut out or fell out or moved.
Okay, so side note, we did have a kid with a collapsed lung once. Tell me a little bit, what is that? Like how do you reinflate it?
Okay, so the kid's going to basically suddenly have severe chest pain and have shortness of breath. And they're like not going to be able to continue moving. And so you don't need a stethoscope. You can put your ear right up to their chest, and you may not hear breath sounds, and you'll hear breath sounds on the other side. That right there, they can make it to the hospital, because all you need is one lung. You can cut one out and live on one. The problem is if it's from trauma, they can have what's called a tension pneumo, which there's a fracture. So what you need to look for is, are they having pain and shortness of breath? And you need to be looking at their trachea. If it's starting to deviate, to one side, their blood vessels, the neck veins are going to be distended, then it's what's called a tension pneumo. You better have EMS on the way, and actually stick a needle, and you stick it right between the ribs anteriorly, below the second interspace, and you punch a hole and let the air out. Now, you guys aren't trained for that, so just call EMS, but that's emergently. And then what we do is, once they get to the emergency room, we used to put a big chest tube in, which is about as big as my thumb. And now we put what's called a little pneumodart in, which is like my finger, and it just goes into the lung, usually in the axilla side, and it just takes the air out that was collapsing the lung. They're not very comfortable.
All right. So again, that doesn't really relate, but it does help me understand kind of, again, what you do. Again, we're talking about referring to the next level of care and understanding your value and what you bring. And then it just helps me kind of relate and anything like that. Just personal interest. Okay. And so again, Emily Anderson mentioned that some emergency departments will say, "Hey, this kid doesn't have a concussion. They're out 2 weeks," and then they're cleared. And again, we kind of mentioned the backwards way of saying, "Hey, what head rule did you use? The Ottawa head rule to rule out any sort of concussion or rule out this?" And then you can begin the conversation there. Or also you could include the note like we said, but there's a lot of times kids will get hurt on the weekend or at a tournament, and then the parents take them without being seen by us. But that's a different situation. Um, so, is there any other thoughts you have on as far as emergency department saying out 2 weeks and then cleared?
Actually, you could again on the note you could steer them. So to research for this, the CDC website has got a really good heads up web page computer page for parents, for students, for docs, and they have a concussion return to play form that I printed out. So if doctors don't know the normal protocol, then you can say, we'll assume that if everything's fine, that we'll institute the CDC's recommended return to play. And that way you're not having to take their 2 weeks, because the return to play, if there's no symptoms, is like 5 days. Does that help?
Yeah. Again, it's just how can we better understand and build that relationship there?
And that's
Um,
that's knowledge. Docs, again, if I didn't research and keep myself up to date all the time, and the return to play has changed even as recently as in the last year when they were redefining concussion, because docs won't say this is a concussion because they want leeway to have an evaluation based on everything that they see. So they're not going to pin themselves down to a hole. But the CDC's done a really nice way to help standardizing it, that we can use.
Yeah, that's one of the things that we as athletic trainers we have to learn. Like, oh, I think he has a concussion. Well, now he has to go through it. And instead, one of the things is like, hey, look, we're gonna evaluate. You don't have this symptom or this symptom, this symptom. Yeah, you got hit in the head and it hurts, but almost anytime you get hit somewhere, it's gonna hurt. So let's look at the symptoms. Let's check it out again tomorrow morning. And instead of saying, hey, I think you got a concussion, we need to check you out. Well, now you're locked into that one thing. So
Yes.
again, just like you said, gaining the understanding personally, and then finding a way to communicate that with. Um, we kind of mentioned the fact that you now have a little bit more experience with athletic trainers and having a conversation with me, but Caitlin feels that athletic trainers are misunderstood and therefore they're not depended on, or someone else mentioned they're not referred back to for follow-up care uh, as emergency department. So uh, can you talk a little bit about that, just the misunderstanding, and then how come emergency departments don't refer back to the athletic trainer?
Well, the emergency departments only see them one time with the initial injury. Usually we refer them for especially for sports injuries, excluding concussions, then we refer them back to their family doctor, because we're not going to be able to see them, as they improve. And so part of it's ignorance and not knowing what athletic trainers do. And the other is the fact that we're not really doing the follow-up to interact with the athletic trainer. And that's where you also would want to reach out, if you have a hospital system of the family medicine, to do an educational training uh, expose to say, okay, family docs, this is what we do. Use us, because we have, you can't say I have more expertise with the muscles than you do and I'm more current, but technically that's what you're trying to say is, use me. And then you could put your name out within the family practice community. And of course that's going to be harder. But another way is each state has a local family practice association, and they do local meetings. And that would be something that you could hit, like all of North Florida. You could hit almost all the North Florida doctors going to a CME conference. You could do a lunch presentation. This is who we are. This is how we interact. Use this so we improve patient care. And family doctors, if anybody, are really open and they want to take care of the patient. And that would really be a good tie-on, even more than emergency docs, who are pretty locked into their one scheme.
All right. So as far as being referred back to or for the follow-up care with the athletic trainer, you were more likely to have success in meeting with family doctors. So just going through looking at the physicals and saying, okay, well, here's a list of 30 people who gave physicals. Let me try and set up a meeting either all at once or over the next 3 months. I'm going to try and call or meet with them and saying, here's who I am, here's what I can do, here's what I would, here's how I can help improve the patient healthcare and improve communication. That would kind of what you're saying.
Yeah. So be a local contact for a hospital system or the local Academy of Family Physicians and try to get into their meetings. Or just get blurbs out.
Again, with our situation with Houston Methodist, the most of the time that those athletes we've already called, and one of our team doctors is going to be involved in the situation because one of them is on call or available to go kind of check out that athlete or follow up with them, and then they're already put right into the system. And it's not like go follow up with somebody else. It's like, okay, well, we're going to schedule you for your follow up appointment with Dr. Brooks on Monday, or with Dr. Woodridge or Rios or whoever it is this week. And so then they're already set up to go through that pipeline that makes the communication with us really easy. But it's those the local ERs that I personally haven't built that relationship with. Again, I'll put that on me for not reaching out. And I've had this idea, I've had this conversation before about what I need to do, because I've had actually my children's doctor, my own personal children's doctor, come and on the podcast, and we were talking about what can athletic trainers do, and she gave me some ideas, and I started doing it, but I just didn't follow up with it because I got busy, and no
Right.
excuses, I just didn't do it. So,
and you're looking at 30 years ago when I trained, pretty much athletic trainers didn't exist. So they've shown that it takes about 30 years for new information to get into the medical community, unless current day of age, we're doing podcasts, you're doing Facebook, and docs are keeping up. So we're getting new information in. So this is the way to do it. And as I said, I just chanced upon your podcast. It's like, oh, this is cool. This is fun. And this is how we're going to get the word out.
very good. Yeah, I'm excited. And it was one of the coolest things for me when you're like, hey, I'm an emergency room doctor. You were talking about the eye. I think it was a retinal explosion or something. Not explosion, but it was something with the eyes.
Blown pupil.
What's that?
The girl had a blown pupil and they're worried about concussion, and she
That's
didn't
what it
have
was.
headache or anything else.
Yeah, I knew it was something blown in eye, and I just couldn't remember. And so she was talking about the blown pupil, and she's like, "Hey, this can help your listeners." And so that's super cool for me, because that's what I'm here on the podcast for, is to improve athletic training. And then now I'm building a relationship with you. So I really appreciate you reaching out. And anyone else, if you have advice, comments, definitely reach out to me like that. Rebecca, Brittany, Sky, and Allie also said that that a lot of times the note will say they were seen in the ER on this date and may return to school or sport on whatever date with no injury, no mention of the injury or what was seen for follow-up required.
Again, that's going to be individual by the physicians. They can just go with the note that's in the computer, or they can come up with their own. So to customize it is time. I've already customized mine, as I said, for return to play. We always usually refer to their family doctor for follow-up if they're still having symptoms, and now actually I'm going to modify mine as like, or your athletic trainer.
See, there you go. And again, if you don't know your situation with athletic trainers, then it's hard for you to say, go see your athletic trainer at your high school. But if I come and say, hey, Dr. Gale, I'm Jeremy, I'm here at, South Vincent High School. If you see any of my kids, then, please just refer to me, give me a call, text, email. But that's because I haven't established that. And so again, now that you've been on this podcast, you're going to be able to add that to your note. And because we've reached out to each other. So any other ideas there on how to effectively do that with somebody who is not as open to change or having athletic trainers?
Oh, that's trying to change behavior. That's a little bit harder. I think it's just going to be the note to begin with, opening up the communication, and the other thing is, as I put in my email, you're going to put the link, was it FP Notebook for just regular injuries, bee stings, burns, sun exposure. So your guys can use that app or the website, and it tells them just local stuff to do for injuries that they're not familiar with.
Yeah, I have the link included there. It says FP Notebook app, and then like she just said, it's got lots of other ideas or resources, ways to treat injuries if you're not used to it. And again, you can even include that in your thing saying, hey, I use this for stuff that I'm not familiar with, but here's what I am familiar with. Again, establishing that relationship before a situation is important, but is not always going to happen. Um, so, real quick, kind of as we're in the middle of this, tell me a little bit about what the scenery or the numbers of ER doctors that are in your practice, like, and you said you work till 1 in the morning. So is there, you work 1 day, 2 days a week. So I'm going to have to try and find 10 different doctors for one hospital, or what does that look like there for you?
Well, I just finished working with one system, and we had 250 emergency physicians. And we had 10 hospitals and urgent cares from Georgia to North Florida. And I literally so that would be, you'd have to just reach out to the person that is the head dog that does all the scheduling, because then that would be the feeder to give them information, and they can just email the information out to everybody. And now I'm in a hospital that we only have 15 of us. I work 4 nights a week. And so then it'd just be whoever's got the contract for the hospital, because for us, it'd just be one hospital, and then you feed it through them. So in Jacksonville, there'd be 4 hospital systems. So literally, if you had 4 contacts of the 4 systems, you could feed it out to everybody. So, you really could be efficient with that.
All right. So again, it's not necessarily knowing each individual doctor and charge nurse and that kind of thing, but it's knowing the head of the system so that they can communicate that or give you the best number for this system and kind of build that relationship. And that person, the ER director, can say, hey, in the city of Houston, almost all high schools have athletic trainers. Please consider putting that in your notes. Must follow up with athletic trainer if you don't feel like they need to follow up with the physician, but they still need to do something. And so, kind of continuing on right there, as we're talking about that 2 weeks and then return. One of the things that I see often is the doctor note 2 weeks and then return to sport. Well, we believe in physical therapy doing rehab. Is that something that you include in any of your notes, saying do physical therapy or athletic rehab with your athletic trainer, or do you mention physical therapy rehab at all?
Again, that's changed. So 30 years ago, you had an injury. It was rest, don't do anything on it, till you've healed, 6 weeks or so, when it was a major injury. And again, that's completely switched. Now we're doing early physical therapy. So I mobilize my patients like the next, as long as it's not a fracture, pretty early. I broke my toe, I'm walking on it that day. It's like I'm not jogging for a couple of days, but as soon as pain can tolerate, then you advance. So I'm incorporating that. But again, that's training, because not all the doctors know, especially the older doctors, if they're not in emergency, they may not even be certified in emergency medicine. They may just be doing it, moonlighting is what we call it. So they won't even know that, okay, you don't rest it for 2 weeks. You actually want to get back there. Back pain used to be go to bed, don't move it. Now it's just like, the last thing I want you to do is stop moving. I want you to keep moving. I want you to be doing low resistance, range of motion, and things like that. So again, that's an educational back and forth. And you guys are probably more up to date on the current stuff than a lot of the doctors.
Yeah, you guys have to go to CME stuff or continuing education courses just the same as we do, but ours focuses on different things, whereas you're focused on how to use a pinky-sized pneumo dart rather than a thumb-sized pneumo dart, where we're like, okay, well, how do we do the rehab? How do we do patient-based outcomes? Or, how do we look up if an ankle is injured? We look at the knee and the hip and even the core, that kind of thing. So how do we check at the whole body, the whole kinetic chain, rather than just, okay, well, there's an ankle injury, you need to sit it and then walk on crutches for 2 weeks or whatever it is. We instead, like you just said, we get them moving. We say, okay, if it's not getting better, we need to refer you to the doctor, that kind of thing there. So
that's where you guys can lead us. So on the CDC, on that website, that concussion return to play form that they use, on it is something that the doctor then literally checks off. Okay, return to play protocol. Here, you guys instituted, cleared for return to play, for complete. So it gives the levels. And so you're literally giving that to doctors. Like, is it okay if we follow this? So instead of waiting for them to institute it, it's just like, oh yeah, I'll follow the protocol. And you can do the same with injuries. Is if their injury, doesn't require bed rest, can we institute the standard return to play physical therapy? In which case, then it's back in your court. And that would help the doctors are like, oh yeah, I want to do the current standard return to play stuff.
yeah,
I lead them nicely.
Okay. Brittany asked if there was, again, I'm not there in the room, so I don't know what the doctor said and what the patient heard. Sometimes it's just lost in translation, but sometimes she said she sees discharge notes are different from what the patient was told, and so that could be as far as, okay, well, it is broken, but then the discharge note says it's not, or maybe it's saying, you're okay, you should be able to return to school tomorrow, but the note says out for 2 weeks, no sports. Can you speak to that situation just a little bit, even though it's vague?
Now, the federal government required all hospitals to use electronic records. So discharge instructions are pre-programmed in there. And unless the doctor customizes them and saves them, then sometimes what they say is different than what's written. So we're in the same process of adjusting. So mine, I actually customize. But then I make sure I give them, because the nurse could come along behind me and say what she thinks needs to be done. So yeah, there's a big room for improvement on that. And so we're working on it, and you guys just bear with us.
All right, I've personally seen this before, not so much recently, but back in the day, Leah mentioned that every time a kid went to the ER with like an ankle sprain, they came back with an air cast. And as athletic trainers, for the most part, we don't use those because they're not like functional. They're something that's going to keep it still from moving. Is there a specific relationship with air cast that they have with emergency departments?
They must have done some kick-ass PR and selling them, because that's all we have other than doing an OCL splint that we've custom made. And the patients actually expect something, at least the parents do. So, usually, okay, here's what we got, and actually we can modify our instructions, so I'll often say the grocery store has sometimes got better splints than we have and cheaper. So, try this, see if it helps. And all we're doing is just mobilizing it for the first day or two for pain. And then we want to get them back to moving it. So it's just because we don't have anything else other than just an ACE wrap, which doesn't do much of anything. We don't have strapping. Nobody's been turned on taping techniques for stability. So again, that's something that, yeah, we need to improve. It's not going to happen. Hospitals get them cheap. So that's all we have available. But it's a good point.
So I've talked before with like Don Joy or some of the DME, the bracing people. And so if there was a specific brace that I wanted our local ER to carry, then it would be my job to say, hey, Jared, I would really benefit from you going to the ER and talking to them. I'll go with you, or these are my contacts. Can you see if they can get these braces to give to fresh ankle sprains, that kind of thing? So again, if I reach out and say, this is what I want, can you, as the brace people, go talk to them? Then that's more likely to happen in that way, right?
Yes. But again, you get your family practice and your ortho. What are they going to be using? Because that's who they see, and whatever we give them, if they don't like it for follow-up, since they're going to be seeing them multiple times, they're going to change it. So more bang for your buck if you want a certain splint is what ones are you coordinating with ortho that they're going to be using, that you guys are using conjointly. And then if you guys agree, then you could bring to the ER, this is what you're going to be using. It's this price. It's just as good. Then we would buy it.
Gotcha. Okay. So that's kind of a big conversation, but headed in the right direction. Right. Misha also mentioned not referring back to ATs for follow up care, but I think we've covered that because you, Dr. Gale, don't know any of the athletic trainers there in your area because they haven't reached out to you. And so again, that's on us for reaching out, building that relationship, and letting them know that we are here and available. Um, and then part of our job is dealing with concussions and saying, okay, I don't think you need to go to the emergency room, or hey, you do, you need to go to the emergency room and get this checked out. Um, but one of the complaints is that the kids will try and go back to the ER to get cleared from that concussion. Um, do you have that situation at all?
I haven't, but I've had patients come back to get cleared for just any injury. And the emergency docs are not trained to say you're back to standards. So some just aren't interested and refuse because they're feeling like they're medically liable. Again, my family practice training, I evaluate them and it's like, oh, okay, yeah, you think you can go back? I think you can go back. Yeah, you're fine. I'll sign the form. So that's not their purpose. They'd be actually better going to an urgent care or a quick care being released.
All right. So in general, they're just not trained to do that, and then a lot of times it may not be the same doctor that saw them before, so they can't just so, oh, okay, well, can you clear me for this injury? They need to go follow up with their PCP or something along, or the ortho that they were referred to, or that we sent them to, that kind of thing.
Right.
All right. Another issue is I did a podcast with Jeff Hopp, which is actually out there in Georgia, um, about HIPAA and FERPA. So FERPA is the Federal Education Public Records Protection Act or something like that. And it's saying any records that are collected by the school about that student are protected, and I can't share those unless there's like a need to know basis kind of thing. But then HIPAA is about healthcare to healthcare, and so one of the issues we have is, well, you're not a healthcare provider, or you're not in direct line of this care of this athlete. Whereas as the athletic trainer, I am a healthcare licensed healthcare provider, and I'm in direct need to know access health, and line of care for this athlete. um how can I help that conversation with my local ERs?
Well, until I started listening to your podcast, I didn't know you guys were licensed healthcare. So it's just letting the docs know. It's like, oh, you may not know, but I'm licensed in the state of da 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 da, and so you can share information. And docs that are okay, old like me, we were around before this stuff, and we can talk to anybody about patient care. So we're not as hung up about the insurances. It's more the secretaries and the nurses freak out. It's like, I can talk to anybody about the patient as long as they say it's okay and it's about their care. I said, we're just doing this to take care of the patient. And when you're doing the right thing, you're not going to get into trouble. So you start, oh, you get their social security number. I mean, all that fraud crap just doesn't happen, but that's what it's to protect from. So basically it's just letting the docs know, because they basically have no clue that you're in the healthcare, and I have no problem having a two-way conversation. And that's, again, phone numbers, emails, text.
All right, so again, it comes back to education on my part. The school board member didn't know who we were because we didn't tell them. So then we started giving them information, providing them like some T-shirts and inviting them into the classroom or into the athletic training room. Again, Dr. Gale doesn't know who we are because we didn't tell her. We didn't go and say, hey, local emergency room doctor, this is who we are, this is what we do. We have to go there and make that communication and make that step, because as athletic trainers know, there is a misunderstanding that athletic trainers are not personal trainers. So people assume athletic trainers are personal trainers and that we're fitness professionals, when we're actually licensed or certified healthcare professionals. So if you're having that issue, you need to establish that relationship and say, hey, here's who I am, here's what we do. All right. So I feel like we keep coming back to that. And then Anne Marie asked, you mentioned before the discharge notes are pretty blanket, but
Mhm.
you've customized yours. So unless a doctor has gone in there, customized them, then they're going to be just a blanket, okay, he's got ankle sprain, so auto populate, this is all the stuff to do for an ankle sprain, you're out 2 weeks, go home. So unless they've said this is exactly what I want for ankle sprains, and you're going in there and typing each one, then it's going to look pretty generic and safe for each injury you see, correct?
Correct. And at the new hospital I've been at, I've been there 1 month. I haven't had time to customize all the notes. I mean, I was at my prior job for 12 years. So I had just about everything customized like I wanted. So it's also time for me to even catch up to then go through and read them and then modify them. So time.
All right. Brittany asked about building rapport. So again, you'd mentioned uh, saying, okay, well, what rule did you use so that I can know kind of where you're headed? And then like if you're speaking a similar language, so if you're speaking medical terminology with them, then they understand, oh, this is a license, this is a healthcare provider. They understand what we're doing. Um, and then you're not like, well, this is who I am. You need to do what I say. But it's like, hey, how can I be involved in the healthcare of this person? And so just starting that conversation, starting it early and not just whenever there is an issue with an athlete or a patient. Um, what are the thoughts as far as building that rapport or positive relationship with ER?
Um, we have a medical department meeting once a month. In smaller emergencies rooms, we'll have them once a quarter. You could even just come or ask to come to the meeting for 5 minutes to introduce yourself. Literally, one athletic trainer could introduce athletic trainers for the entire city, just the fact that you exist, and educate the docs. So that's another way other than the local family practice meetings and the local ER contacts. It's going to take time, but I think we're all, I mean, I'm kind of excited that we're all trying to get to the same place.
Yeah, and it's again just breaking old habits or being willing to step out. It would take a lot of time for me every Monday say, okay, well, from uh, 11 to 2 every Monday, I'm going to be out of the office visiting the dentist or the local ER or the family doctor just to meet them, say hi, this is who I am. And again, there's so many in our area, and we have kids that'll drive like 45 minutes for some reason to go see a doctor when there's one like 5 minutes away. But if I made that commitment to say every week I'm going to go meet one or two of our local medical providers, then they're going to know who I am. They're going to know who athletic trainers are. And I've already started building that relationship. And then when I need something, they're going to know who I am. They're going to be willing to work with us and again, take care of the athlete.
And I just had a brilliant thought. We're doing this through podcast. Well, one of the ways I get new information is emergency medicine podcast. I'll send you the most popular ones because they're reaching millions of docs. And even if you got on there as a 5-minute blurb, tell your ER docs that are listening to this that we exist, you'd literally in 5 minutes disseminate to 1 million doctors. So I'll send, that would be really cool. Oh, cool. So I'll send you those contacts. That might be something cool.
That'd be really good. And then maybe we can, I'll just drop your name there. Hey, Dr. Gail sent me this. Okay. Some of the resources that you mentioned, the MD Calc, which has a lot of rules and guidelines for Canadian C-spine, Canadian CT head rule, Nexus C-spine rule, Ottawa ankle rule, Ottawa knee rule, pediatric asthma score. You already mentioned the PECARN, the PECARN pediatric head injury rule, the Glasgow coma score, and then the FP notebook app. Again, I have a link to all of those in there, or you could Google them just the same as I did. Again, this is sportsmedicinebroadcast.com/ER doc. So I've got those links that Dr. Gale provided. I mentioned Justin earlier. He said some of the things that they're doing. And again, he's working in a hospital, and I mentioned that they have an ER doc that kind of splits time between sports medicine and ER so that they're all on the same page. They also do regular rotations. So each athletic trainer, I think he said, has to complete 3 hours in the emergency room each year. Again, observing, seeing what they do. And again, that builds relationships and says, hey, we're athletic trainers. Hi, we're learning. We're here. We're part of the team. And so doing something like that is very good. we mentioned so many times sending out some sort of note, some sort of communication to them. He said just sending out a one-page thing saying, "Here's the latest concussion guidelines. Here's what we're following. Here is when we're available. Here's our phone number, email, that kind of stuff." Um, Several people had mentioned having a liaison, somebody in the middle saying, "Hey, you have any kid that needs to go to the ER, you call me. We'll get them in." He also said that in their situation, they build the emergency room for supplies that were damaged, so like splints and that kind of thing that were damaged or not returned, because I guess they're in the hospital so they can bill across. Have you ever seen anything like that?
We don't have that here. The orthopedist might.
Yeah. I don't know. Again, that wouldn't work. I couldn't I couldn't say, "Okay, Pasadena High School sending the emergency room a bill for my splints." I don't think that would work at all, but if that's your situation, then maybe that'll work for you. I mentioned the 3-day rotations, and then they do equipment removal and spine boarding with as many of the residents as possible. So, like you just said, the medical residents are learning those things. So some of them are coming to do game day observations with us. But if you said, okay, hey, every July 30th, the athletic trainers and the ER doctors, residents, we're going to get together. We're going to discuss equipment removal. What's the best practice, again, including the EMS. And that way, the whole chain of command kind of thing is there together. And you're building positive relationships. You're working together. You're saying, not this is how we want to do it, but you're saying, what do you guys think? This is how we do it. You guys practice here because I know you guys don't have football equipment there at the ER to practice with, but we got it here. So those kind of situations there. And then lastly, said education of parents, like we mentioned before, talking to the parents saying, "Hey, don't go to the emergency room to get cleared. They're there to make sure nothing's broken or you're not dying. Don't go to them to get cleared um, for your concussion or for your staph infection. They're going to send you to your primary care physician." And then also, a lot of times when I tell my kids, when I send them to the doctor, I was like, ask questions. If you don't understand, don't let the doctor leave the room. Make the doctor speak in words you understand. Make sure you're clear. Have you ever had anybody say, "Hey, doctor, I don't understand what you're saying. Can you repeat that?"
Not me, because I'm really good at breaking it down. But other docs are yes. But people are intimidated. But you got to ask. I think it's a great idea.
Yeah, one of the things that Dave Ramsey has said is like, "I'm the one paying the bill. So if I don't understand, you're not getting paid." Right. And so he's like, if you don't understand, don't walk out and don't pay them for advice that you don't even know what it means, right? Make sure that you understand your options, those kind of things like that. So educating the parents and the athletes on ask questions, be sure you understand, clarify, and those kind of things like there. So, all right, Dr. Yale, I really appreciate your time. I really appreciate you listening and sharing and being a part of this. Any other thoughts for athletic trainers to improve our relationships with our local emergency rooms?
No, just keep the door open. Always assume that they're busy and that they want to have a relationship. Never judge. Always give them the open door. You guys are doing a great job. I'm just really excited.
Very good. So we mentioned EMRs. You know that Dragonfly is a great EMR. I've been playing around with it, and it's got lots of opportunities for documenting notes, or even doing the verbal dictation of notes, that kind of thing. Um, and those things can be sent to the patients, the athletes. So if I say, okay, well, dislocated ankle, laterally reduced on field, uh, felt like there was movement in the fibula, then I could put that in the notes, send that to mom. Mom can show that to the ER doctor. And again, it's not the same as having it on a piece of paper that you can keep and put in the notes, but it's having that communication with the parent, the athlete, and the doctor. So that's a great option. Again, Dragonfly Max, if you're an athletic trainer looking for an EMR. But without much further ado, Dr. Gale, thanks so much. This is sportsmedicinebroadcast.com/ER doctor. Again, sportsmedicinebroadcast.com/ER doctor. Dr. Gale Marjoram from Jacksonville, Florida area. I am pleased to have you as a guest and to share your knowledge. And I look forward to getting those podcasts and continuing to share the knowledge of athletic trainer, or the abilities of athletic trainers, with other ER doctors. Thanks, Dr. Gale.
Thank you very much. Have a great day.
You too.